if we sort of know what's going on, and especially in the minds of the folks in Washington, feds, Medicare, and everything else, and we sort of know what we need to do to be able to succeed in this new healthcare environment, this transition of healthcare, which is, mostly about this healthcare reform bill / law that is being actively bantered about in the Supreme Court. Certain aspects of it, okay, not the aspects that I'm talking about today, although a lot of people would say that if the Supreme Court overturns that aspect of healthcare reform, then probably the whole thing may go kaput, and it'll be back to the drawing board again. I personally don't think that's going to happen. I also personally don't think that what Medicare wants to do ultimately is going to change, and I don't think that the stakes are going to change, and I don't think that what we are going to have to do is going to change, okay? So I'll say that as a basic premise. As a regional medical director for J.A. Thomas is a documentation improvement company. If you don't know who we are, if you get requests to sort of, you've written one thing in the chart and somebody's suggesting that maybe you write something else, one of your clinical documentation folks, we're 100% behind it. And there's a reason for it, and the reasons have changed over the last few years, and it has everything to do with healthcare reform and how we're going to survive in this environment. If you're wondering why healthcare reform passed and why it passed now meaning about 2 years ago, it has a lot to do with money, specifically the government's money, and even more specifically Medicare's money, and trying to keep Medicare afloat, trying to keep Medicare alive and thriving well on into the future, because you heard prognostications several years ago that Medicare was going to go broke, basically, by 2017, 2018, if they didn't change the way they did business. There's a large disparity in the way Medicare pays hospitals versus how they pay providers, for one thing. Everybody built individual silos for another. And so Medicare wants to do several things, one of which is to coordinate care a little bit better. And there's going to be rewards to hospitals and physicians and organizations that can sort of prove to Medicare that they're coordinating care. And that's, if you heard accountable care organizations and so forth, that's what that's about. Beyond the scope of really what we're talking about today to really get into much about accountable care organizations or bundled payment initiatives and things like that, which are all driven to try to get everybody on the same page and to do things together. We'll quickly mention that. But basically what they want to do is they want to start paying for quality. We are sort of in a profession as physicians and other healthcare providers where we've survived for many, many years being paid for services provided with not much of an eye towards quality or outcomes and things like that. And while we can all sort of agree that that it's okay in principle to pay us based on performance, I guess you could say, or quality, the question everybody has is, how do you really represent quality? And how do you do that? And how do you make it fair? And how do you make it so that it really means anything? And so I wouldn't say that Medicare is not concerned about that, and I wouldn't say that other rating organizations are not concerned about that, but I would say it's a difficult thing to do, and I would also say that they are less concerned about whether things are absolutely 100% fair as much as whether they are able to really come up with some good data and some good statistics to be able to compare hospitals and compare docs. And the motivation is, if just having your reputation dragged through the mud out on the internet is not enough motivation, this is rapidly shifting into some percentage of pay based on how we sort of do on all these quality report cards. Some large and growing percentage of our pay is going to be based on how well we do quality-wise, and I'm here to tell you today, if you don't know already, I'm going to throw out a number. 80 to 90% of how well we do on quality numbers doesn't really have to do that much with actual quality. I would never say that it has nothing to do with quality. Taking good care of patients has always been in style, always will be in style. That's why we get into healthcare. That's why we get into this profession, is to take good care of patients. But how we document in the medical record is going to be huge, really huge, when it comes to these quality report cards being established. And that's one of the take-home messages that I want you to walk out of here with today, because that's what value-based purchasing is all about. And Congress mandated that Medicare needed to shift over to this value-based purchasing plan years before healthcare reform actually came down the pike, okay? And then healthcare reform bill, that was in response to, partially in response to this congressional mandate. This is the long-term goal. This is the cornerstone of what Medicare wants to do to A, improve quality, B, improve coordination of care. Those two things go together. C, financially salvage Medicare, okay? With the basic thought being, you know what, if we pay based on quality and we grade everybody on a curve, and we stack the odds in our favor, then they can't really lose. And that means that if they decrease reimbursements and they grade everybody on a curve and they shrink the pie, and you essentially have to sort of prove that you are a good quality hospital or physician to earn your money back, so to speak, to get to where you were before, rather than just being paid for services provided. Some people are going to do, but just the nature of being graded on a curve, most people are going to be towards the middle. You know, some people are going to do well, some people are going to do poor, and you can, if you adjust reimbursements, Medicare reimbursements, you can slant it so that, you know, you have to make money, okay? And that's what the casinos do too. Now, in the short run though, the other part of healthcare reform that we'll spend a few minutes talking about today too, because it's pretty interesting, and there's a lot of documentation issues involved in that as well to help protect ourselves, is the idea of this kind of expanding and burgeoning denial industry. This is a very quick way for Medicare to make money. The RAC audits you may have heard about, the recovery audit contractors, the MACs, Medicare administrative contractors, you may not have heard about, but basically these organizations are set up to deny claims upfront, retrospectively, everything in between, and these are all documentation issues. What they're essentially doing is they're looking for lack of documentation so that they can deny payment, okay? So everything we're talking about here today has to do with documentation. So the Patient Protection Affordable Care Act passes over 2 years ago now. It's hard to believe it's been that long, and part of that bill was that Medicare needed to set up this essentially committee or group that came out with the whole sort of plan, the multi-year plan for inpatient value-based purchasing, pay for quality, and the final rule was put out about a year ago, a little over a year ago, just over a year ago, and essentially what it called for was to start payments based on quality to hospitals to start with this October. So just 4 or 5 months from now, maybe 6. I can't count the months ahead in my head very well. Some percentage of hospital reimbursements are going to be paid based on quality, and the measurement period that's going to be the basis of these payments is already done. It ended March 30th of this year, started last July. So a 9-month period of time where, whether you knew it or not, Medicare was measuring this hospital and all other hospitals in order to establish how much money was going to be paid to the hospitals based on quality. Some relatively small percentage to start with, and then over the years it's going to increase. The number of measures we're being judged on is going to increase, and the percentage of pay based on quality is going to increase as well. What does Medicare call quality? Number one, core measures. We all know about core measures, okay? This is 1/3 of what Medicare calls quality, how well we do on core measures. Bunch of documentation implications in there. They've been around for about a dozen years. Heart failure, acute pneumonia, as well as surgical patients, the SKIP project. I'll give you an example of one of those in a minute, and we'll talk about some of the documentation implications. Clinical outcomes. We think these are better, actually, because core measures are just process measures, evidence-based guidelines, don't have anything to do with really whether patients do well or not. Outcomes measures sort of do. But the question is the way Medicare measuring outcomes measures fair and equitable, and how much of it has to do with how well we document on the chart? Because all outcomes measures, number one, same 3 diagnoses, by the way, so far, are severity adjusted. They take into account severity of illness and risk of mortality, okay? If you're looking at mortality data, you're looking at observed mortality versus expected. Expected mortality is the risk of mortality, and how does Medicare establish the risk of mortality? It all has to do with our documentation, and maybe in a way that you know, and maybe in a way that you don't really know, and it's a little bit strange the way they do it, okay? But it doesn't really have to do with how sick the patient actually is. It has to do with how sick we demonstrate that the patient is through our documentation, the coding process, and the DRG assignment process. Okay, now I just said DRG and coding, and so I sort of shut everybody's brain off a little bit, but hopefully not, because it's pretty interesting and frustrating but interesting. And if you are in a hospital that has a program like this, where you have folks actually kind of going behind you, making sure we wrote the right things, or are writing the right things, then you certainly are in a position to be successful in this environment. Hospital-acquired conditions, too, in addition to these outcomes, mortality, readmissions, length of stay. And so that's a documentation requirement, A, because those are severity adjusted as well, and B, we may or may not know that coders need to code something as either present on admission or hospital-acquired, and if we don't state that we've paid attention to that and documented it kind of one way or the other, at least to the best of our knowledge, then a lot of those things will be coded and construed as hospital-acquired conditions, therefore raising the rate of hospital-acquired conditions for us individually and for the hospital, and there'll be penalties to pay for that as well. So that's another third of what Medicare calls quality. Finally, the patient experience of care, the HCAP survey. It's been around for a few years and totally subjective, okay? And it's not a documentation issue so much, it's a being nice to patients issue and spending time with them and doing all those things that we need to do, and knowing all those little tricks to make patients perceive that we actually spent a lot of time in the room, okay? There's something about, I remember reading something about if you sit down on the bed next to the patient and just sort of touch the patient on the arm, you could spend a minute in the room and the perception is that you've been there for a half an hour. You could stand for a half an hour between the patient and the door, you know, kind of moving like this slowly as you're talking, and you could spend a half hour doing that, and it's perceived to be about 30 seconds. So, but it also ends up being important whether we're emptying the trash cans in a timely fashion, whether the room's quiet, what the food is like, just sort of all these things that we don't really have any control over. So here, real quickly, I'll show you some Medicare data that I just pulled off the website within the last couple of days, so you can see how you're doing. And this is not the data that Medicare is going to use to actually sort of do this value-based purchasing payment this October. They collected a new set of data that hasn't been published yet, but this is the previous data that's out on the website. And this is, we're going to talk a little bit about pneumonia today. I'm going to give you a clinical example or two regarding pneumonia as well. And this is how we're doing on this particular core measure. Pneumonia patients given the most appropriate initial antibiotic. What is the most appropriate initial antibiotic? Well, it depends on the pneumonia. This is a measure of simple pneumonias, community-acquired pneumonias. So the question is, are we demonstrating through our documentation that a simple pneumonia is a simple pneumonia, or have we, through our documentation, done something else? Have we admitted somebody with a non-simple pneumonia, non-community-acquired pneumonia, but it got thrust into that category because of the coding process and the DRG assignment process that we didn't really understand? And there's a lot at stake here, because the better we do on core measures, the better we all do. So we're right on the national average at 94%. We're actually better than the New Mexico state average. But does anybody believe that 6% of the time we give people the wrong antibiotic when they get admitted to the hospital for pneumonia? If you do, raise your hand. Okay, I don't think so either. I was just showing you how to raise your hand there. And so the question is, what are the documentation items that are pretty important to make sure that we are getting people into the right category? Okay, so that's core measures. That's a third of quality with regards to the way the government and Medicare looks at it. Now, these are one of those outcomes measures. This is the 30-day death rate for pneumonia patients. Now, if I was to tell you that this is 30-day death rate for people that get admitted and discharged from the hospital with a principal diagnosis of pneumonia, 30 days later, they're no longer with us for any cause whatsoever. They may have died from pneumonia. They may have been hit by a bus, okay? I don't know if people are really hit by buses anymore. That's more of like a sort of a big city thing, but I always use that as an example. And so it doesn't take that into account. But what it does take into account is the severity of illness of patients, and so it has everything in the world to do with documentation. And you can see that the national average is 11.9%, and we're at 12.5%, so we're a little bit higher than the national average. We don't like that, we don't believe it, okay? We think we're probably at least average or better than average, and it's a little bit more frustrating when you think, okay, this is outcomes data that Medicare is going to use to kind of decide how much they're going to pay this hospital. And inevitably the physicians in this hospital, okay, whether we're employed or not. And these are 30-day readmission rates for for pneumonia. You can see the news here is a little bit better. We're actually better than the national average, 16.6 compared to 18.4. These other hospitals that I tried to compare to didn't have enough data to really sort of contribute. You guys are sort of an island of a hospital here. There's no other sort of sizable hospitals for, I don't know how many miles, 40 or 50 at least, right?
70.
That's what I meant to say, 70. So it's not like people are going, you know, in some places where there's a cluster of hospitals, the concern is that patients are going to like use this type of data to pick which hospital they go to. Here, it's like there's not as much of that concern, but there is the concern of the reputation of the hospital as well as reimbursement. So all the same things apply to this slide too. So we're doing better here, okay? We're not doing, you know, as well here, okay? And, you know, so what conclusions is Medicare drawing from this combination of data? Who knows? But they're looking at all the numbers, and, you know, they may say, you know, unless you're doing good on both of them, they could say, you know what, the reason your mortality rate is so high is because you don't readmit people very often. Maybe you should readmit them a little bit more. Maybe you should do something else. Your readmission rates are low, but your mortality rates are relatively high. But so much of it has to do with documentation through proper, and we got to get people into the right data category, just like with core measures, and we also have to establish severity of illness. Now this is recent data. That other data has been on Medicare's website for several years. This is new. This is like 4 to 6 month old data here. And so and this is hospital acquired condition data, and it's early data. Medicare's not going to use this for another year or two probably as they get more data. But you can be compared on 8 different hospital acquired conditions compared to the US national rate. And you can see on most of these you're doing, you know, really pretty well. The only two where you're higher than the national rate is on falls and injuries. So the question is, is it a documentation issue, or is it a sort of protocol, sort of hospital systems issue? Are people actually falling too much? Or is it also that we're just kind of saying patient status post-fall, and we're not commenting as to whether the fall happened prior to the admission to the hospital or during the admission? If we don't specify one way or the other, it'll be coded as a hospital-acquired condition, okay? Same thing for infections from Foley's. Are people coming in with Foley-related infections, and we're not documenting that we believe it's present on admission? We're just writing Foley-associated UTI, you know, DC Foley, whatever, antibiotics, and it's being coded, not because coders are ornery and want to do this. They just they live in a very much of a rules-based environment and need to code things based on the way things are documented in the record. This is another parameter that Medicare is going to use. And then this is the HCAP survey. Here it is, communication with doctors, but a whole bunch of other things too. So the point here is that one grumpy patient can really sort of kill you a little bit, as much as, and this is really frustrating to doctors and other healthcare professionals, you know, this guy hurts you as badly as if you know, have bad outcomes or don't do well on core measures, you know, or don't document well. So it's pretty interesting times. Now, why should we care? Well, we care about our hospitals, and we're going to be associated with our hospitals as well. But I got all that data off this website called hospitalcompare.hhs.gov. There's also a website called physiciancompare.hhs.gov where Medicare is doing the same thing for us individually as physicians, okay? And they feel like they have enough data as of December so that they are willing to share this data on individual physicians to employers, insurance companies, and consumer groups like Health Grades and the Delta Group and these other companies that rate doctors, okay? They haven't published the data yet. But if you know the way Medicare works, what happens is, and I read the USA Today a lot because I travel a lot, you wake up one day and you open up the newspaper and it says, hey, Medicare now has, you know, all this quality data on doctors on its website, physiciancompare.hhs.gov. Look it up and see how your doctor's doing. And you'll get on there and there'll be core measure data on you, there will be mortality data on you and me, and readmission rates and all these different things. So it hits home. Whether Medicare is really going to use this as a source of, you know, reimbursement to us in the same way as hospitals remains to be seen. But even if they don't do that, really what they want to do is ultimately Medicare wants to pay all of us together. They want to kind of eliminate all those separate silos. They want to incentivize everybody to do the same thing. And they would love it if every doc in the country was employed by a hospital and everybody would just work together to coordinate care and do well on quality measures and all these things. And that's why they're launching, national pilot projects this year on these things called accountable care organizations, okay, that sort of strongly suggests that hospitals and physicians should work together in its simplest form. It doesn't have to be that way, but that's the way Medicare wants it to be, so that we all work together to kind of do well on quality measures and efficiency measures, and then ultimately pay us all together based on DRGs rather than billing separately whether we're employed or not. So what do you think the national trend is towards physicians being employed? It's rapidly, rapidly growing. And I'm not just talking about hospitalists like myself. Neurosurgeons, cardiothoracic surgeons, everybody. Everywhere I go, the trend is upward. Right now we're somewhere between 50 and 60%, I believe, nationally, all physicians. The expectations in the next 3 to 5 years is it's going to be between 80 and 90%. And it's because of what's going on, okay? People are sort of seeing the writing on the wall. So what does this have to do with better documentation? George Bush wants to know. We're pretty close to the state of Texas, I guess. It's not really George Bush. Everybody just says it looks like him now. So what if there was a university hospital in Washington, and we're looking at mortality index, and so that's the observed to expected mortality ratio overall. The standard is to be at 1. In other words, you want your observed mortality to be about where it's expected, if not better. And the top university hospitals, this is the University Hospital Consortium, the top university hospitals are well below that, okay? Trending over like a couple of years, okay? And what if you put a documentation improvement program in one of these hospitals here, and then over the next 2 years, you watch the mortality index drop right down into the same range as the best university hospitals in the country. And you haven't done anything else at this hospital. I'm not going to say you haven't done anything else. I mean, they may very well have implemented some quality measures, sort of improved their hand washing protocols, or changing Foleys more often, or changing lines more often, or whatever they might be doing, okay? But really the main thing you've done is that you've, just really the main thing you did was you improved documentation, and look what happened to this hospital. Why is that? Well, because as I mentioned, it all has to do with sort of documentation, has to do with coding, has to do with the DRG assignment process, and the verbiage that coders need to effectively and accurately code a chart is different and oftentimes counterintuitive to what we write in charts, because we were trained whenever we were trained and wherever we were trained and had the mentors that we had, and we write things, though similar, very different. So we might write the same thing 20 different ways, and coders have one way that they need to see it so that they can code it effectively and accurately. So it has DRGs are where it's at primarily, and then there's this thing called the case mix index, which we probably don't know what that is either. The CEO and CFO know what it is, but a lot of us as physicians don't know what a case mix index is. And so DRGs have been around for almost 30 years, okay, and they came around as a way for Medicare to simply pay hospitals. Everybody got placed into a category, a DRG, regardless of what your diagnosis was, and there were a bunch of diagnoses and things lumped together based on sort of clinical similarities and also cost similarities and expected cost, average cost similarities, and so you got placed into one of 500 and something categories, and that's how Medicare paid hospitals. Then they changed the DRG system about 4 years ago, 4.5 years ago, to the Medicare severity DRGs that are now 750 DRGs, and a better system, they think, for payment, but also for sort of looking at severity of illness, okay? That's why they're called Medicare severity DRGs. And so it turns out this DRG assignment is not the only component, but the largest component of what Medicare calls severity of illness, and it's all based on coding of principal diagnosis, simple pneumonia versus complex pneumonia, secondary diagnoses, all sort of contribute. Only 1 or 2 of them will contribute to the DRG assignment, but all of these secondary diagnoses, if they're coded appropriately, will contribute to severity of illness, the denominator for all of these outcomes measures, okay? And these are called CCs or MCCs for complication or comorbidity or major complication or comorbidity, okay? So, and then each one of these 750 DRGs has a relative weight that averages around 1, and then a case mix index is sort of an average of a whole bunch of DRG relative weights over time. You add them all up, divide by that number, and you get what's called a case mix index. Hospitals have one, and guess who else has one? Each individual physician in this room has one. Medicare has a case mix index calculated for each one of you, and it has to do with 100% with how well you have documented over the last few years, okay? So, but it's a fluid thing, and the better we document each day, you know, we could positively affect our case mix index. And so let's go through a couple of cases now, and we'll sort of kind of see where we're at. And we're going to talk, since we've been talking about pneumonia, I'm going to try to stay on that topic for a little while, and we'll talk about this elderly woman who's got a little bit of baseline dementia, some chronic respiratory problems. She's been admitted to the hospital a bunch of times and comes in with all the signs and symptoms of pneumonia, and she's hypoxic, and her vital signs otherwise all look out of whack as well. She's also acutely confused and agitated, well beyond her baseline, okay? Chest x-ray shows a pneumonia, left lower lobe, and so we get her admitted to the hospital, and she's put on broad spectrum antibiotics and fluids and frequent vital signs, frequent neuro checks. You know, this change in her mental baseline is very concerning. We all know that when patients come in like this, there's about 100 bad things that can happen to them in the hospital. Sputum cultures are sent off, and they're not really very helpful, and blood cultures are sent off, and they eventually come back negative. And the physician documents through the medical record and in the discharge summary, and she goes home after about 5 days or something like that, 6 days. She kind of beats the odds again and survives, because she is an 84-year-old woman, nursing home patient. So, you know, there's no reason in the world she shouldn't survive and do well and go back, only to come back into the hospital again probably a month later. But we document nursing home acquired pneumonia, okay? We also document severe acute respiratory distress on admission with severe hypoxia. We also document baseline dementia with severe acute alteration of mental status, okay? Or if she's not combative and she's kind of lethargic, we may say that she's acutely obtunded, okay? That's about as good as severely altered mental status, okay? And the coder takes all this information and says, how should I code this out, okay? And he or she does that, and it falls into this DRG that's called simple pneumonia without any comorbidities, okay? And the relative weight of that DRG is 0.7, and the anticipated length of stay is just under 4 days. And remember, we just said she stayed 5 or 6 days. I can't remember what I said. Medicare calculates an anticipated length of stay for each DRG assignment, okay? So that's not really it doesn't seem to be a very accurate categorization. This documentation seems like it's pretty good. That doesn't seem to really be a good categorization. But luckily you're in a hospital that has a clinical documentation improvement program. One of your CDSs, the simplest thing they could do, there's more, but the simplest thing they could do is kind of say, hey, you've got your patient, we're looking at the history. We know that there's a huge risk here that this is probably a gram-negative pneumonia, and that's what you're treating for. You've got double gram-negative coverage. Do you think this is probably or possibly or likely, or do you suspect that this is a gram-negative pneumonia you're treating? And could you be a little bit more clear that this was maybe present on admission and the patient didn't develop the pneumonia in the hospital, that it can't be construed that way? And so if you agree and you change your documentation to presume gram-negative pneumonia on admission, or suspect gram-negative pneumonia on admission, that one little thing changes the basic DRG. It doesn't get you any comorbidities yet, but it changes the DRG to 179, which is sort of a complicated pneumonia. The relative weight goes up to 1, at least average, and the anticipated length of stay is more in line, okay? So the point here is that these things that we always write, myself, I'll speak for myself, I won't speak for anybody else in the room, where the pneumonia was acquired, nursing home acquired, healthcare acquired, nosocomial, even ventilator associated. Coders, it's not that coders don't care where you got the pneumonia, you're certainly welcome to write all these things, and even if I describe it as severe, acute, and life-threatening, horrific, worst pneumonia I ever saw, it's still just going to be a simple pneumonia unless I describe at least what I believe I'm treating. Suspect aspiration, likely gram-negative, whatever, at least sometimes, not all of them. If I say suspect pneumococcal pneumonia, that's still a simple pneumonia. But these things, if you at least document something like that, in addition to that, then you'll get credit for a complicated pneumonia. Properly categorize the patient. As long as you're stating what you believe is going on and what you think is treating, and even if you do document that on 100% of the charts, and nobody's suggesting that you should, and nobody's suggesting that we shouldn't document 100% of the time what we believe, and let the chips fall where they fall. I mean, you know, yeah, your rate of sort of complicated pneumonias is going to go way up, and should. And then what happens? What Medicare does? Yes, they will notice through a process, through the, you know, quality improvement organizations and the MACs and everything else, and they'll say, hey, alert, alert! You know, down there in Alamogordo, all of a sudden we're seeing a spike in complex pneumonias. And then the fiscal intermediaries, the MACs, are going to look at those charts with a little bit more scrutiny, which is fine, as long as you believe what you write and you're substantiating what you write. Patient's been admitted a bunch of times, lives in a nursing home, has COPD, chronic respiratory failure. This is likely to be a gram-negative pneumonia, and I'm double covering for that. I don't have a culture to prove it, but that's what I'm treating for. That's what I think it is. So, you know, good medicine and good documentation, and we don't have to worry about the fact that somebody may be looking with a little more scrutiny, as long as we kind of are documenting sort of what we believe. So what have we just done here? Well, we've appropriately removed this patient from core measures for simple pneumonia, okay? That list of antibiotics, remember that core measure I showed you a little while ago? Selected the most appropriate antibiotic for simple pneumonias. This patient was going to be categorized in simple pneumonias. What are the chances that we were going to select one of those antibiotics off that list for simple pneumonias? Slim to none, and slim just left town, as they say. So we've properly categorized the patient. We've increased the sort of severity of illness and the risk of mortality and risk of readmission and risk of everything else bad that can happen through accurate description. And we've also described the pneumonias being present on admission. Okay, so it won't be construed as a hospital-acquired condition. But there's more, because this altered mental status description, and we always get MRIs on people with altered mental status, right? Because that's cost-effective. Kidding. You know, that's altered mental status we taught as a symptom, not a diagnosis, just like obtunded. It's sort of a clinical description. It's not really a diagnosis. There has to be something underlying it. So the question is, what is it? Is it an acute delirium, or is it an acute encephalopathy? And if you've researched this topic like I have, or if you're a neurologist, any neurologists in the room? Clinically, if you look up one, it's kind of, the terms are almost used interchangeably if you look at Harrison's online, which I don't think anybody does. Everybody looks it up to date. But they're almost used interchangeably clinically. In the coding world, they're quite different, though, because altered mental status, or obtundation, gets you 0 credit through the coding process. Delirium gets you a little bit of credit as a minor comorbidity. Encephalopathy gets you a lot of credit as a major comorbidity. Okay? Why is that? I have no idea, but that's the way the rules are right now. This is the way things are in the meantime. What's more, every codable diagnosis falls into a diagnostic category, and delirium is categorized as a psychiatric diagnosis. Encephalopathy is categorized as a neurologic diagnosis. Sometimes one's more appropriate than the other. So here's a chart that takes into account what the DRG assignment is going to be with the relative weight based on nursing home acquired pneumonia with altered mental status, delirium, encephalopathy, or suspected gram-negative pneumonia with altered mental status, delirium, encephalopathy, and look at the range of relative weights that can be assigned based on how we document things. You're familiar with this one, and if we get this all right, it can be 3 times as high, okay? This is severity of illness and risk of mortality. This patient that we're looking at here, what do we think her risk of mortality is? Is it a her? It was a her. What do we think her risk of mortality is? It's relatively high, right? Is it her 30-day risk of mortality? 15, 20, 25%? So is that more accurately reflected by a relative weight that's less than average, or one that's about twice as high as average? Okay? So that's what it's about. It's about realizing what's going on through the coding process and DRG assignment process, realizing that that's how the risk of mortality and risk of morbidity is established, and then we're better armed with the fact that this patient actually does have a significant risk of dying, okay? And that's not even to mention if we think the patient has acute respiratory failure, okay? which there's no real strict criteria for. Blood gases help, but they're not even mandatory, and you don't have to be on the vent. But the point I want to make is that, you know, she was described as having acute severe respiratory distress with severe hypoxemia. That gets coded as a respiratory symptom, similar to cough. So you get as much severity credit for writing severe acute life-threatening cough as you do for writing severe acute life-threatening respiratory distress. It's respiratory failure or it's not. Yes, based on blood gases, but what if you can't get a blood gas and somebody's breathing 35 times a minute, their sats are 80%, and they look like they're going to die in about 5 minutes if you don't, you know, do something, even if you don't end up shoving a tube into their face. But this is the kind of thing that we write, and we feel like we're demonstrating severity of illness, and we kind of are to ourselves and to our colleagues. Severe acute life-threatening nursing home-acquired pneumonia with severe acute respiratory distress and profound hypoxemia gets coded as a simple pneumonia with no comorbidities. Okay? So that's the point. Ridiculous? Yes. But true, yes.
So on your documentation, would you go back and put acute respiratory failure, secondary to tachypnea, hypoxia, patient was using accessory muscle?
Yes.
Did you do that in your documentation?
Clinical substantiation is what you're talking about? Like, this is why I'm calling it acute respiratory failure? Excuse me, failure? Yes, absolutely great. From the standpoint of some medical director at some MAC office or whatever not saying, yeah, okay, you use the right words, but I'm not really seeing it here. Yes, substantiation is great, and I was going to talk about that in a few minutes when I start talking about the RACs and MACs, but it's a great point. It really helps. Yes, sir?
Just one comment. So these are
Just one.
Tricks. These are tricks, and we're just discussing pneumonia. As you know, there are hundreds of diagnoses, and this is going to happen everywhere. I think the only way we're going to get this is that if the electronic medical records give us a drop-down.
Yes.
When we are coding, the drop-down automatically, and then we say, okay, how do I make it a higher DRG? That's the only way I think it's going to happen. Because you're just going to tell us about pneumonia. There's a zillion others. How are we going to remember all this?
Well, yeah, the EMRs...
It's impossible to remember all
that.
this.
That's for the coders to remember, Doc.
No, but then you will be calling us, can you make it gram-negative? It's not going to work.
So what I think is it's right, and you're raising a good point, and it's sort of a multidisciplinary approach. It'd be great if there was a really good EMR that had drop-down menus that only used smart phrases that were like the right ones. And that's all well and good, but then the smart phrases change a little bit too, which I was going to mention in a minute. And so the EMR has to be fluid. The other thing we could do is we could sort of become coders or documentation specialists and memorize all 800 of the strategies that are in the software. I don't know about you, but I already have a full-time job. I assume you do too, or like a job and a half. And so really the answer is sort of, you know, what Jackie was inferring there, that, you know, we do the best we can, and we have little cheat cards that you can keep in your pocket for the top 15 things that you might see. But you need it all. You need a good EMR, you need to kind of be as aware as you can, and you need a documentation improvement program to kind of take the onus off you, do the best you can, and know that somebody's coming behind you and kind of saying, okay, you wrote this, if it's okay with you, only if it's okay with you, because we're striving for accuracy, not higher DRG assignments all the time. Although most of the time, if you better documentation does lead to that, but not always. And sometimes you'll get a request to specify something that will actually decrease the relative weight of the DRG, but will actually sort of categorize the patient correctly and just reflect a more accurate chart. It's a little bit of everything, and it's never going to be perfect. Never, ever, ever going to be perfect. You know, all we're suggesting is that we document as best we can, utilize the help of the program that's in place, use these cheat cards if you want to, push whoever your EMR vendor is. What EMR do you guys have here? Okay, which is a pretty good one, believe it or not, on the scale of things. And it's amazing how far behind the EMR industry is, really, with regards to all this stuff. It's really, really frustrating, but hopefully it'll get better, you know. But, you know, so it's a little bit of everything. It's a great point, though, and it's really frustrating because there isn't that one good answer. Real quick, just a couple of quick hitters, and then we'll get into the RACs and MACs a little bit, and then that'll be it, unless you want to stick around for a little bit of I-10. Just things that docs everywhere sort of have trouble documenting because it's not our normal lingo. We write things like this: chronic hypoxemia, O2 dependency, OPD, end-stage COPD, severe end-stage O2 debilitating COPD, and none of those things will get you credit as a comorbidity, but chronic respiratory failure will. That's a comorbidity. How do you define chronic respiratory failure? Well, you have to have chronic lung disease from something. Sometimes you have a home O2 requirement, but you don't even have to in the strict definition. Would I document chronic respiratory failure for somebody that's not even on O2? Probably not. But I'm not forbidden from doing so. And the ICD-9 book has a definition of chronic respiratory failure as a persistent, non-severe decrease in pulmonary function. Well, I've just described almost everybody in this room. Aren't we all sort of progressively losing our lung function a little bit? So now, I'm not suggesting that we get that fast and loose with it, but it's like if somebody's on home O2 and they have chronic lung disease and they have any restriction of their ADLs based on that, they probably have chronic respiratory failure, and then when they come in the hospital like this woman, it's acute on chronic, which is coded and construed the same way as just acute. Doesn't matter if it's acute or acute on chronic. But the use of the word failure is key, okay? And then does this woman also meet criteria for sepsis? And the criteria for sepsis are a little bit stricter, and the critical care docs defined this in the 90s and redefined it in the early 2000s, differentiating between bacteremia, SIRS, and then sepsis, which is SIRS due to a documented infection, regardless of whether you have positive blood cultures or not, or any cultures, okay? And severe sepsis is with end organ dysfunction. This woman technically has severe sepsis, really, with a brain being an end organ, right? And so you could also say, in addition to acute respiratory failure, that she has, severe sepsis, right? She doesn't have septic shock, probably, or at least there wasn't any documentation of that. And by the way, we still use words like urosepsis. How does that get coded? As a UTI or pyuria, as opposed to sepsis due to UTI, okay? And so that's another one. And just another reminder, the coders can't do this for us. They need us to sort of use the right terminology. That's why the CDSs help us so much, okay? Because we don't always know the right terminology. The things that we see all the time, we'll learn, okay? But we don't know all, there's about 800 strategies in their software that they're looking at. Signs and symptoms are not good diagnoses. We gave you a couple examples of that. And more and more coders are becoming reliant on complete and timely discharge summaries. Complete doesn't mean thanks. Complete doesn't mean long. It just means kind of having all the key information in there. All the significant diagnoses, principal and otherwise, et cetera, et cetera. There's other things that are important in there too, med recon and all these things. But from the coder perspective, sort of summarizing things and having it have to do with sort of the rest of the medical record. This is really important. I think I mentioned it, but I'll mention it again. Documenting our thought process. Okay, we don't have to know what's going on, but if we suspect it or we think it's likely, we document it. If it looks like we're treating based on our presumptions, then it'll be coded as if we were 100% sure about it. How often are we 100% sure about anything? That's another topic for another day. And then the consistency thing in the chart is the other things, particularly with turnovers with hospitalists, but everybody's turning over patients these days. One person writes one thing, acute respiratory failure, somebody else writes acute respiratory distress or hypoxemia or something like that. Confusing to a coder. Coders will generally code it, not confusing to somebody like a rack auditor who's going back to look for that lack of consistency in the medical record to ask for money back, okay, based on the fact that the chart was coded as acute respiratory failure. Morbid obesity as well as severe malnutrition. We know if people are morbidly obese or severely malnourished, clinically it's very important. People stay in the hospital longer and need more intensive care in a lot of different ways when they're morbidly obese or severely malnourished. Whether it comes to just sort of helping patients with things or wound healing or whatever. And then the documentation of the BMI, in addition to sort of the clinical scenario, is important as well and won't be coded or construed with maximal severity of illness. Even though these patients that have BMIs greater than 40 or less than 19 really stay in the hospital longer, they're sicker, they're increased risk of everything and utilize a lot more resources unless we document the condition with the BMI, morbid obesity with BMI 45, severe malnutrition with BMI 17, whatever. These will be coded as major comorbidities, and they should be, because these folks are just more sick by virtue of the fact that they have these things, okay? But you need the condition, you need the word severe or morbid, and you need the BMI also, okay?
Excuse me.
Yes?
Should we go off of BMI? Because I know around here they do the pre-albumin and the albumin. So do we do the BMI, or which way should we play the Medicare game?
So low albumin we
That's a loaded
classify
question.
as severe malnutrition.
Yeah, I mean, I think the
And we
albumin...
don't have a BMI, will that work or we need the BMI?
Well, there's probably a BMI calculator on every patient that comes in. I mean, a nurse does it, and it's in the nursing notes somewhere, and you just have to know where it is. So everybody gets a BMI, and I don't know if it's done daily, but at least on admission, everybody gets a BMI, and you can always request, you know, sort of a height and weight on the patient and age, and you got your BMI. I would say all the above is great. I mean, typically we always get an albumin if we order like a Chem 18 or a Chem whatever, there's an albumin in there. It sort of fluctuates though, it's sort of a fluid thing. Nutritionists will see most of the patients that come into the hospital, and if they see the need, they'll usually order a pre-albumin in most hospitals. All that data is important, I guess, clinically to make your determination. From a documentation standpoint, that's all you need though.
Because it's a
You can
big deal.
substantiate it though with that.
BMI is a big deal, you know, we deal with old folks who come to the hospital on gurneys and stuff. Nobody sees how tall they are, they just weigh them and put them on the
You
bed.
just sort of go, hey, you know, about 6 feet.
5 feet, seven.
But
Yeah.
if their albumin is...
Yeah, they can't stand up, is that what you're saying?
Then
Yeah.
they're eating more Twinkies.
No,
Right.
it takes height.
And so if you feel like you don't really have a good, accurate sort of BMI, then ordering an albumin and pre-albumin can be sort of helpful, just clinical
The
substantiation, I
BMI is a
think.
required field on every admission, but
Yeah.
it's always a reported weight, so
You know, and hopefully it's not like,
Go to ICU.
and how accurate is it, you know, how accurate is, in every hospital I've ever been to, you know, it's always like, it's my big pet peeve, I might as well bring it up here, respiratory rate of 20. You know, so question is like anybody really sitting there and measuring respirations, or people really accurately weighing? We have to make sure that the processes in the hospital are giving us accurate information, to be sure. Random items, handoffs we talked about, problem lists, Cerner keeps a good problem list, but we don't always update it. Discharge summaries we talked about. Documentation clarifications are answered and addressed that day, but then we fall right back into saying the same thing that we were saying before. We get asked, and this is a hospitalist kind of problem, but it's an everybody problem. You know, we don't want to sort of amend documentation based on sort of what was going on a day we weren't here. I would do that, and I think we would want other people to do that for us. We use the word insufficiency all the time rather than failure, especially with renal. Renal insufficiency is coded as like nothing. Severe acute renal insufficiency is sort of, adds no severity of illness to a patient. Acute renal failure does, or acute kidney injury. And most nephrologists, anybody a nephrologist in the room? Acute kidney injury or acute renal failure. How much does the creatinine need to go up to call it acute renal failure? It's like 0.3 or something, right? 0.3, 0.4. We are not as comfortable doing that as nephrologists are. We're not going to get a nephrology consult on every single patient unless you really want us to.
No.
Do you? You know, so we need to get, we need to just mostly realize that failure is failure and insufficiency is insufficiency, and the two are not the same thing. By the way, acute renal failure used to be an MCC till about 1.5 years ago, and now it's just a CC, acute renal failure. End-stage renal disease is still an MCC, always will be. Medicare decided, I guess, that acute renal failure patients were not really that, you know, we thought they were pretty sick, but I guess they're not really that sick. Is that what it was? Not really. We just got better at documenting acute renal failure, and so they lowered it to like a CC instead of an MCC. This is a game that's going on, since somebody called it a game. Several people called it a game. However, if it's acute renal failure secondary to ATN, it's still an MCC. So how do we define ATN? I'll let you, short of getting a renal biopsy, I'll let you ask this guy in your free time. So anyway, urosepsis we talked about, etc. Okay, so that is the end of my spiel, and that's the bulk of the talk. And And really the umbrella of information is healthcare reform, pay for quality. Pay for quality is not really pay for quality partially, but it's pay for demonstration of quality, and the demonstration of quality has to do with how we document. Thank goodness we have this clinical documentation improvement program here with very smart people running it. Remember, the quick way that Medicare is going to get money back, though, is by denying claims, okay? The MACs and the RACs, okay? What's a MAC? Medicare Administrative Contractor. These are the new fiscal intermediaries that have been rolled out nationwide, okay? I think it's just the nationwide rollout just completed within the last few months, or certainly within the last year. I don't know the name of the MAC for this region. Does anybody? Anyway, what's the big deal about MACs, and what's new about them is that previously there were separate fiscal intermediaries for Part B and Part A. Part B is us, practitioners, submitting our E&M bills. Part A is hospitals submitting DRGs, and those two things went through separate offices. Now, the MAC, the beauty of the MAC from Medicare standpoint is that everything goes through the same office. So you have a non-medical person, for the most part, looking at both claims and making sure that things match up. What do I mean by that? What if you have a low relative weight DRG, like simple pneumonia, with no comorbidities, but I'm billing like level 3s or critical care or something like that? That's not going to match up. All the claims are going to be denied, and then everybody's going to have to like appeal and kind of fight to get their money. Okay, that's part of the evil plan. The other one is inpatient versus ops, which comes into play with the RACs too, which I'll talk about in a moment. Bless you. And what if the patient gets admitted under inpatient, and I'm billing OBS codes because I don't know that the patient was admitted inpatient or vice versa. Those two things aren't going to match up either, and all those claims are going to be denied, and everybody's going to have to appeal for their money. And then I'm glad you said what you said, because the other thing, every MAC has a medical director, and they're looking that not just that we use the right terminology. It's acute renal failure. Why is it acute renal failure? What are you basing that on? You wrote acute respiratory failure. What are you basing that on? Okay, so it's getting increasingly important to do that, and these are, and the clinical, we're going to be relying on our clinical documentation specialists more and more as time goes on. Sorry about that. Now the RACs are designed to sort of go back and find the ones that fell through the cracks. Okay, the claims that were already paid, and let's go back and review and see if we should have paid this claim, and if not, let's ask for our money back. What are they looking for? Two things. They're looking for the consistency of documentation that led to the coding and the DRG assignment. So if everybody's not writing the same things, or it was only written one time or twice, and it wasn't in the discharge summary or whatever, then those are going to be downgraded, and we're going to be asked for a partial refund. The lowest hanging fruit, it turns out, is really the whole medical necessity issue, which is you admitted the patient to the hospital inpatient, they went home in a day or two. Why did you admit them inpatient? Why weren't they OBS? How did you justify that from a medical necessity standpoint? Through your documentation. Why does Medicare care about that? Because they pay out on average about 3 times as much for an inpatient admission as for an OBS stay. Okay? So that's why they care about that so much. So, and the whole RAC, the national rollout started about 1.5 years ago. It was based on a 3-year kind of pilot project in New York, California, and Florida mainly for 3 years. And how much money do you think the government actually was able to identify as reclamation money in 3 states in 3 years based on just looking at these things and the lack of documentation?
2-3 billion.
If you're thinking a zillion?
Billion.
A billion. It was about $1 billion. And the RAC auditors work on a contingency. They're bounty hunters. And during the pilot project, they got 15% of what they found. 15% of $1 billion is, oh no, 150 million, I think, right? And now on the national rollout, they only get a mere 12%. So poor RAC auditors. And so anyway, and so from a medical necessity standpoint, the initial data on the national rollout has identified 5 different diagnoses, 5 different DRGs as being the DRGs that are assigned to the patients with the highest rates of a lack of medical necessity in the documentation. Syncope, inpatient admissions for syncope, chest pain,
Yep.
TIAs and other things that fall into the category of transient ischemia, COPD exacerbations,
Without a CC.
and then if any cardiologists here? People that are getting admitted to the hospital, the principal diagnosis is a procedural diagnosis for a heart cath with a balloon and a stent, but the patient didn't have an MI or some other major comorbidity. So those are them. So what is the strategy? Well, the strategy is, number one, on the back end, to document in a way that we try to get patients out of this DRG appropriately and accurately through better documentation. Was it really syncope, unknown cause? Or was it syncope likely neurocardiogenic or likely vasovagal or due to dehydration and hypovolemia? All those things, if we document that, get us out of this DRG 312 and lowers the patient on the radar screen. Was it chest pain, or was it chest pain due to GERD, or chest pain due to costochondritis, or chest pain due to anxiety, assuming they rule out for cardiac stuff? Was it COPD exacerbation, or was it acute on chronic respiratory failure? Okay? And so with chest pain, so we know this guy's having a heart attack here. You can tell by his arthritic hands.
Because
So
he
we,
has too many charts with a rack target.
what's that?
This is because he's got too many charts.
Oh, that's what it is. That's why
Rack
he's clutching
target.
his chest.
Yeah.
So we know 313 is a rack target. So if we admit the patient to the hospital, they rule out, they have a negative stress test, and we write chest pain non-cardiac, or chest pain atypical, or chest pain, I have no idea. All of those things are going to get coded and end up in this DRG that we know the RAC auditor is looking for because it's number 2 on the list. And I'm not saying they're not going to look at it if we do it here, but not only are all of these higher relative weighted if we state what we think is causing the chest pain, and again, we don't have to be sure, they're higher relative weight DRGs, and that's good, and they're lower on the RAC auditor's radar screen. That's also good. And nobody's suggesting that you fudge anything here, but if you think it was, if you're given a prescription for a PPI, it was probably sort of GI related. If you're given a prescription for Ativan, it was probably, anxiety, So, but then on the front end, and this is probably at least equally important, if not more, state why you think the patient needs to be admitted inpatient, okay? It doesn't have as much to do with interqual criteria, which case managers use, and case managers do what they need to do, which is look at do we use interqual here or Milliman? Interqual?
Yes.
So you look at the interqual criteria, and it's pretty strict, and if you meet criteria, you meet criteria for an inpatient admission. That's all well and good. But the RAC auditors don't just look at that. In fact, they primarily are looking at physician documentation of what the medical necessity is on the front end. And it doesn't matter what happens the next day or the day after. If your level of concern is such on that day that you're going to admit the patient to the hospital inpatient, and you state that, as opposed to, I don't know, something that I've written in charts 1,000 times. Admit inpatient, chest pain, rule out MI. That's my assessment and plan. Or rule out ACS. Low-hanging fruit for a RAC auditor, they're going to find thousands and thousands and thousands of those. They're not going to find a lot of charts that say, admit the patient to the hospital inpatient. I'm concerned about the character and quality of his pain. He has multiple significant risk factors. Looked very sick when he got here. Pain is better now, but I think he's at a huge risk of recurrent pain and or arrhythmias. I'm going to rule him out. He needs continuous monitoring, probably needs a cardiology consult, and I'm really concerned that something bad is going to happen to him if I let him go home, like he might drop dead in the parking lot. And, a RAC auditor is going to go, sees that description, is going to say, next, looking for those chest pain rule out MI charts, okay? So that's sort of the point. So it's not just about interqual criteria. Case managers everywhere I go, they're great. Case managers do perform a number of very valuable functions. But it's not just about interqual criteria. It's about sort of physician documentation. And if we don't care about the hospital losing its money, realize that if the hospital claim gets denied and you collected some amount of money on your billing for that hospitalization, what's to stop a RAC auditor from coming and asking you for your money back? Okay? Nothing is the answer to that question. So, and so there's all these different things, and I won't go through these in detail, but somebody writes, these are reasons why charts get denied. Somebody writes non-ST elevation MI, somebody else writes troponin leak. One of those codes to an MI, the other one codes to abnormal AB. Acute respiratory failure was documented by the ED doc, but then nobody else wrote it after that. No discharge summaries, et cetera, as well as charts being denied for illegible signatures. So just thought I'd throw that in as well. So be careful what we write. Establish medical necessity for everything that you do, whether it's in the hospital or in the office. And keep in mind that it's easier to take somebody that you admit under observation, or place in observation, and shift them over to an inpatient admission. More difficult, more of a red flag if we go back the other way, okay? So part of the solution is documentation improvement, because here's this poor doc, this guy, and he looks like he's about 14. And he's just trying to take care of patients and thinks that, like, lives in this world that, you know, we kind of lived in 30 years ago, where if I just take good care of patients and everything else will work its way out. That used to be true. That was before we had all these bubbles around our head, you know, sort of with all these things that, that I've sort of talked about today. And so the new model is really a collaborative one. And I don't know if you can see that or not, but it's several people sort of collaborating, trying to get the documentation right in the chart. This is the doc, and this is the CDS right there, I guess, or vice versa. That's kind of what we're dealing with, and if we wanted to exist in a situation where the medical record would just go away like I used to, I would say this would be the greatest job in the world if I never had to write anything in a chart. Not only do you still have to keep writing things in chart, but you got to be even more careful about what you write and more thorough about what you write. So that environment is changing in the wrong direction. So CDSs, there's more and more burden on CDSs. It used to be good enough just to get us to write the right words. You know, and that's still important, and that's still the basis of it all, but, you know, due to the max and racks, I mean, they're also being tasked with trying to get everybody to put the right words in the chart. And then also that clinical substantiation thing is getting increasingly important as well. And so, and the format is probably, you guys use the 360 format, something similar to this? I mean, any of these things, and this is somebody that wrote end-stage COPD, chronically dyspneic, chronic continuous O2, blah, 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 to a coder, right, as opposed to chronic respiratory failure. But you always should have choices. Is it chronic respiratory failure, is it something else, or do you not know? Okay, and that's to stay compliant. And also another quick reminder that every request is not just to increase the bottom line, to increase reimbursement, it's to accurately assess severity of illness and risk of mortality and risk of morbidity, okay? The standpoint of being a physician is going to increase the need for us to document better in the medical record, and we don't have to actually learn ICD-10 unless we want to. If we're coders, we have to. If we're not coders, if we do some of our own office, you know, coding, then maybe we'll want to learn it a little bit, but mostly we have to realize that this is going to increase the need for more specific documentation. Up until a few months ago, I was saying this, October 1st, 2013, that's it, that's the deadline, we have to be ICD-10 ready by then, and then of course, like the next day after I said that to somebody, this came out, delaying it for another year. And, which, you know, that's fine, and so you may be thinking, you know, what's the big hurry, what's the big rush, why do we need to convert over to ICD-10, what's the big, you know, urgency? Well, what if I was to tell you that ICD-10 has been around since 1994, first country was England to adopt it in 1995, and the last industrialized nation to adopt it did so in 2001. Now here we are, we were planning to do it in 2013, now that's 2014, so that's it, okay? Now you might say that most of these countries, if not all of them, don't use the ICD system for billing. They really just do it for sort of record keeping more than anything else, okay? So, the World Health Organization is the one that comes up with ICD-9 and ICD-10 and eventually ICD-11. And the World Health Organization also keeps statistics, okay? And rates countries as far as healthcare expenditures and healthcare outcomes, okay? So we're the only country in the world still using ICD-9, which is over 30 years old, outdated, obsolete, ridiculous. It's inaccurate and limited data. It's hit the ceiling. You can't add anything to it, okay? It's kind of landlocked, can't be expanded, and really limits the full benefits of having a good EHR. And when you're comparing international data, it's like comparing apples and oranges, okay? So the last time the World Health Organization did international data comparing one country to another, with regard to healthcare expenditures per capita, how do you think the United States ranked as far as healthcare expenditures in the world? Well, no. Number one, I mean numero uno, the worst, which means you're number one for like per capita healthcare expenditures, okay? Now, where do you think we ranked in the world with regards to healthcare outcomes? And you can argue the sort of outcomes that the World Health Organization measures. But I'm here to tell you that part of the reason that we're so bad is because they're comparing, you can't possibly compare, and it's all based on claims, on ICD-9 or ICD-10 claims, that you can't possibly compare the two, and I'll show you why. But does anybody know how we rank in the world in the early 2000s according to the World Health Organization for outcomes?
6th or 7th?
If you're a little higher, 37th. And just so we know what the company we're keeping, does anybody know who 36 and 38 is? 36 is Costa Rica, and 38 is,
Cuba.
huh?
Cuba?
Cuba's right around there. Slovenia. Isn't that funny? So you wouldn't think that, right? So I said this to a group of people like a few months ago, and some woman jumped up and started cheering in the middle of the room. And she was from Slovenia. She said, "Yay, Slovenia, we're only one behind the United States." Which I'm not sure is a good thing. But part of it, it's multifactorial, but part of it is because we're using this antiquated system. How many ICD-9 diagnoses? About 17,000 or 18,000? How many in ICD-10? Any guesses? 142, okay. Part of which is accountable for the fact that in ICD-9 there is no codes that differentiate laterality. There's no left versus right in ICD-9. Some people say it doesn't matter, but I think in certain instances it does matter quite a bit. If you're looking to see if something's recurrent or new, if it's left-sided again, then it might be recurrent. If it was left side this time and right side the next time, it's probably new. So there's two components. ICD-10-CM will replace ICD-9-CM, and that's the diagnostic part, and then ICD-10-PCS will replace ICD-9-PCS, which is the procedural part. So in ICD-9-CM, the diagnostic part, the codes, the skeleton of the code is 3 numbers, decimal point, 2 numbers, okay? In ICD-10, it's 7 alphanumerics, okay? It's a letter followed by a number, and then either one of the two with a decimal point separating them. So you can see that there might be a little bit more room for expansion there, right? So let's look at one of these codes, pressure ulcer codes. And these are outcomes that World Health Organization and Medicare and everybody is measuring, okay? In ICD-9, there are 9 codes for decubitus ulcers based on general locations. The back, not low back, mid back, you know, whatever. And they don't show the stage of the ulcer at all, nor laterality. How many codes for decubitus ulcers do you think there are in ICD-10?
20.
It's greater than 9 and less than 1 million. 125. Okay, and the codes kind of make sense. It changes, the last number changes based on whether it's stage 1, 2, 3, or 4, and then the second to the last number changes based on whether it's left or right, and another number changes, and this is like on the right lower back, another number would change if it was mid back, etc., okay? 125 codes for decubitus ulcers, okay? So, the ICD-9-CM procedure codes for the hospital, these are not CPT codes. If we're proceduralists and we're billing for codes, we're using CPT, and CPT is not going to change. But the hospital uses a different set of codes to bill procedures, and it's 2 numbers, decimal point, 2 numbers. In ICD-10, it's more than that. It's 7 alphanumerics, okay? And the kicker for hospital procedural codes is every single one of these needs to be filled out. And so it's going to increase. We don't need to know what the code is, but we're going to be asked to document things so that somebody can determine section, body system, root operation, body part, approach device, and qualifier. Okay? If we bill using CPT, if we're a proceduralist, a surgeon, or other proceduralist, what do you think the chances are that if you submit your bill and the hospital hasn't submitted their bill because this digit hasn't been filled in, that you're going to get paid when the hospital hasn't submitted their code yet, okay? So that's incentive for us to want to sort of get this right, okay? So angioplasty codes, in ICD-9 there's one code for it's called angioplasty. Doesn't matter if it's heart, kidney, leg, one code. And if you want to specify what's going on a little bit more, then you have to assign 4, 5, or 6 codes, and somebody has to try to piece all those codes together to actually determine what was going on. So how many codes do you think there are for angioplasty in ICD-10? More than one, less than 1 million. If you're thinking 854, you're correct.
Wow.
Why is that? Because one code, 047K04Z, tells you dilation of right femoral artery with a drug-eluting intraluminal device, open approach, as opposed to angioplasty. Okay? So there you go.
So ICD-9 is better than.
Yeah. Well, you can listen. So you're trying to compare what's going on in the world, and you've got every other country in the world using this, and then you've got the United States using this. And how do you possibly compare outcomes for angioplasties of the right femoral artery? Can't do it. And so a lot of the data is supposition. So the good news is that the major onus of this doesn't fall on providers and physicians. Good news for us, bad news for everybody else. You can learn as much of it as you want to, but we have to realize that when this rolls out, you know, the CDSs are going to be asking us even more stuff because there's more information that they're going to need to get. So just in summary of the whole talk, realize we're going to be increasingly paid for value, and it affects all of us, and we all need to work together, and it's good that this system is here, and it sounds like everybody in the room is, at least, though somewhat cynical, is willing to work together and participate, and really what we're striving towards is accuracy in the chart, and everybody can buy into that. And so that's sort of the basic message. I appreciate everybody sticking around. Any other questions or comments?